Kia ora, everyone. So I'd just like to list my disclosures here with my funding, and also acknowledge, very importantly, acknowledge the people, the land and language of the local Ngāti Whātua tribe, and just acknowledge the warm welcome they gave us on that first day of the conference. And also because my research is mainly with Aboriginal and Torres Strait Islander people in Australia, acknowledge the traditional owners of the lands in the areas my research is conducted, pay my respects to their elders past and present, and also acknowledge my wonderful team that's made up of both Aboriginal and non-Aboriginal researchers. I think it's important to position myself of like, what am I? I'm a Pakeha New Zealander actually who jumped the ditch. What am I doing with this work? Why am I working with Aboriginal and Torres Strait Islander people? So back in, from 2002, I've been involved with developing tobacco programs and was invited into do this work by Aboriginal and Torres Strait Islander health services back in 2005. And I was asked to help, was told smoking is a problem for our people, and can you do something to help us? Because at that time there was really not very much happening. So I started to help, and I'm still helping, and while my help is useful, I will carry on doing that. But what's also really important is to build that capacity so that this research can be led by Aboriginal and Torres Strait Islander people, not people like myself. So building that capacity by having Aboriginal PhD students, Aboriginal research assistants, and I've trained over 100 Aboriginal health workers in different services all across Australia. So today I'm going to talk about why smoking is important in pregnancy, what are the high-risk groups for smoking, what are the some factors that influence that, what works, and what are some of the challenges to translation, and our own model about how we have developed our projects and what recommendations for future research. So just a little bit about the Indigenous health gap in Australia. So the pie chart shows us that there's only a certain amount of that health gap is contributed to by behavioural risk factors. So there's a whole big chunk that's the social determinants of health. And in the blue, there's a bit that said gap due to other factors, unexplained component. Well, I don't think if you speak to any Aboriginal or Torres Strait Islander people, they would say that is unexplained. I think they would tell you about colonisation, dispossession, and racism. I think there's a lot in there that's not on that pie chart, which are very important things. But tobacco is, looking at the bar graph, the most, out of the behavioural risk factors, is the one that has the largest influence on the health gap between Indigenous and non-Indigenous populations. So if we look at over time, this is not specifically smoking in pregnancy, but smoking in general populations. We see the blue line is the prevalence of Aboriginal Torres Strait Islander smoking, and the bottom line with the general population. And yes, they are both decreasing, but there's still that big gap there. And then we can see that in the blue there, we've got the Aboriginal targeted campaigns have only really started around about 2003, but really actually later. And these are some of the things that, so I've kind of been involved with this research really right from the beginning. And, seen some campaigns come through, but, we still need more. So why focus on pregnancy? Well, pregnancy is an opportunity to affect two people's health. That's obviously the really important thing. Mum and baby. And we know also that now we're thinking more of the whole life course, and we understand there's a lot of things that happen in utero that affect, people's life all the way through. And some of those things I'm going to talk more specifically about. But let's not forget the risks for the mother. So the risk for the mother in pregnancy is that she can have miscarriages, preterm births, a lot of placental problems, bleeding from the placenta. She can get ectopic pregnancies. Some of these are obviously life-threatening for her. And for the baby, well, the one that most people know about readily is low birth weight, which has a whole load of sequelae in itself. And the low birth weight that we tend to see with Aboriginal and Torres Strait Islander people has now been shown almost exclusively to be due to smoking in pregnancy. And then we have a whole raft of other things that influence the baby, so they can obviously also have preterm birth, stillbirth. There's a lot of respiratory problems when they're born. They can have neuropsychological problems, learning problems, behavioural problems, cancers, diabetes, obesity, and they're much more likely to become smokers themselves. So, there's also a lot starting to be known about the epigenetic effects. So pregnancy is considered a critical window here. And if we look at babies that have a poor environment in the womb due to what's called a poor maternal forecast, who then come out who have a more rich environment with more adequate nutrition, etc., are then set up to have metabolic diseases later on in life. And quitting is worth it. So I suppose it's horrible to think of monetary terms, but, at all stages, if we can prevent one baby having a low birth weight, the health service saves $4,000, and that escalates right up to $210,000 with a baby if we prevent one sudden unexplained death in infancy. So the high-risk groups for smoking in pregnancy: Indigenous women, women with mental health issues, women who use alcohol and other drugs, and also the influence of those social determinants of health, the women who are in low socioeconomic circumstances, and these do tend to overlap. I'm going to focus my talk today on Indigenous women because they're the people I work with most. So if we look at the comparison between the rates of smoking in Australia and New Zealand, we see they're quite similar. In the general population, we're doing really well. It's like about 10 to 12%. But then in young women, we have higher rates. Women in low socioeconomic circumstances, Indigenous women, fairly similar. And then we also, in Australia, have very high rates in very remote areas. And then here's the kind of what's happening in pregnancy specifically, similar to what I showed you before. Both are going down, but we've still got this really big gap over time. So some of the barriers for cessation. This is based on a systematic review I did back in 2013. So we have, there's positives and negatives, and most of it, unfortunately, is on the negative. But some, for example, the influence of family is a bit of a yin and yang thing. Family can be very supportive, but they can also, because a lot of smoking in the families and social norms of smoking, it obviously can detract as well from quitting. Smoking is used just to get women through the day if they've got stressful lives, difficult circumstances. Just knowing about the harms of smoking is not enough to change behaviour. And there's a lack of salience of messages. So, the messages out there are not really targeted to pregnancy and not really targeted to Aboriginal women. And then you've got these larger things that are on the outside, about the socioeconomic disparities, the colonisation, dispossession, the stolen generation, and for those who don't know, it's the forcible removal of babies from Aboriginal and Torres Strait Islander women. And we know there's a definite link up there with smoking, and a lack of access to services and essential medications. So what works in pregnancy? So I'm going to talk about 4 things: the messages, counselling, nicotine replacement therapy, and incentives. But just a reminder there, we don't know how these translate over to Aboriginal and Torres Strait Islander populations. So health messages. We know health messages are effective and health campaigns like that. Aboriginal and Indigenous populations generally prefer culturally appropriate messages. There's only been one campaign aimed at pregnancy in Australia called Quit for You, Quit for Two, which has got some sort of target towards Aboriginal and Torres Strait Islander women. It also targets Asian women who have very low smoking rate, like about 2%, but it's kind of a mixture of both. And, you know, that comes on TV, not very often, and there is a little app you can get. And about 40% of women that were interviewed who were Indigenous said that it did make them want to quit smoking. That we can help you quit, you're not alone, is a message that we use in one of our projects. It's just a reminder there that it's really important to build up self-efficacy for quitting. But few messages really tell this chronic disease story about babies. So people just don't know that. It's not in the media anywhere. And messages can be too scary. So we've heard from Aboriginal Torres Strait Islander women that, you know, if I see a message, you know, thing on TV, if it's scary, I go out of the room, I just have a smoke. I don't want to see them. I don't want to look at those plain packages. I always ask for the one that doesn't have the baby on it. And that other picture is an artwork done by a young Aboriginal person with a project I run in schools. And we can see actually the young people are actually quite scared they're going to lose their parents through smoking. And, you know, we also have that frightening message, effect of the messages on children. So when we look at counselling, it's kind of like a catch-all phrase, but like, what is counselling? We know counselling doubles chances of somebody quitting if it's used with other components in an intervention. And when you kind of try and drill down what makes up counselling, you come to what type of behaviour change techniques are in there. And there's now a taxonomy of behaviour change techniques, and we know that things like helping people set a quit date or problem solve, you know, all those sort of things that are individual behaviour change techniques that we can use. And we do know which one of those, there's some emerging evidence about which of those behaviour change techniques are useful in pregnancy, but we don't know anything about what behaviour change techniques are effective for Indigenous pregnant women. And also in Australia, we're still very hooked into this stages of change and only offering help to people if they say they're ready to quit. And but the Cochrane Review tells us that stage-based interventions are not as effective in pregnancy, probably not really effective at all, and you're kind of wasting time just actually asking people and trying to weigh up those pros and cons. The more important thing is to offer everybody help with quitting, irrespective. It's not the motivation they come in the room with, it's how they feel when they go out the room that's important. So we can actually influence that by offering everybody help to quit. Nicotine replacement therapy in pregnancy. So in the health provider's mind, there's a whole lot of questions. Is it safe? You know, is it effective? And they're not really sure how to use it. So when we look at the safety, we've had about 2,000 women go through randomised controlled trials in pregnancy using NRT, and there's not been any adverse effect for the mother or the baby. So far so good, but there's some people who say, but is it really safe? Well, it is safer than smoking. And, you know, most experts agree, most guidelines would support that, you know, if women can't quit, they should be offered nicotine replacement therapy. But we do have a faster nicotine metabolism in pregnancy. So women do actually need higher doses. So by being very cautious and tentative and not giving women very much, you're actually doing them a disservice. But we don't actually have any higher level trials in in pregnancy yet, using higher doses. So it's all a bit of an unknown. And then on the woman's mind, for an Aboriginal and Torres Strait Islander women, we know from our qualitative research, they feel it's their job, they should quit alone. They don't feel they should be asking other people for help, and they don't really know where to go. And also they have that question, is it safe to take? Is it going to harm my baby? And women, when they do take it, they don't tend to adhere to the, even in the general population, they don't tend to take enough of the NRT. They don't seem to take it for long enough. So adherence is a big issue. So it's kind of like you have to sell it a bit. But we do know that it does increase your quit rates at about 40%. So it is effective in pregnancy. When we look at incentives, this is where actually one of the biggest effects is. So these are 3 times as effective as usual care. And so the number needed to treat is only 7, which is really quite good when you think about it. But although I have heard that in New Zealand here, offering incentives is quite routine, a lot of services do that in pregnancy, it's not routine in Australia. And there was a study in Tasmania, for example, that did offer vouchers for women to help them quit. And, quite just a little bit of social media comment on that in Australia. And we have had some studies that looked at this specifically, that there's a bit like, it's not very acceptable in the general population. And also, we did actually a few years ago have a round table that was run by the Luitja Institute, which is one of our national institutes for Aboriginal health research, where basically everybody sat round and decided that this shouldn't be offered to Aboriginal and Torres Strait Islander women for some reason. I wasn't there, so they didn't ask me. But anyway, we have some of this discourse about, that women might be shamed for, accepting an incentive to help them quit smoking. So the guidelines in Australia, we still use the 5 A's, but most people can't name the 5 A's. Recent study, I believe, with cardiologists in America, none of them could name all the 5 A's. You have the ABC in Australia, which aims to sort of get quite more quickly to that cessation. Let's talk about quitting. And generally, the counselling should be offered in the first instance, but NRT should be offered if a woman can't quit. And, we may need to use combined oral NRT with a patch. But what are health providers actually doing? So this is a systematic review we conducted, which across 10 countries, 7 high-income countries and 3 low to middle-income countries. And this were the results, pooled results of often and always, how often or always they did these things. So you can see we're quite good now about asking and advising pregnant women to quit smoking. But where we start to fall down, it goes down the slippery slope, it's when it comes to assisting cessation, helping her make a quit plan or setting a quit date. And particularly NRT is really low. So see if I can use that thing. No, don't know how to use that pointer. Okay. So assisting with NRT is pretty low, and even arranging referral. And we don't have it on here because there wasn't the data, but arranging follow-up, we did a similar study in Australia with GPs and obstetricians, and arranging follow-up was like only 7%. It was really low. So we know where we need to intervene. But what can we do to help improve that? So we know training increases smoking cessation care in non-pregnant people in the general population, and particularly if doctors receive training, the quit rates double in their patients. But we don't know if that works for pregnancy. So we did another systematic review of the literature to look at what interventions can help health providers improve their smoking cessation care, which was led by one of my students, Yael Baziv. And we found that there was, for ask and advise, was that there was some difference from the interventions overall, but with the ask, the only significant thing really was having a theoretical framework to your intervention, and for advise, having audit and feedback looked effective, and also having interventions that had 3 or more components. But they were only fairly moderate changes. So how does this evidence translate for pregnant Indigenous women? So there's only been 3 randomized controlled trials worldwide to date, and none of them have shown any difference between intervention and control. So we had Sandra Eads-led one RCT in Australia, which looked at intensive counselling versus usual care. And there was a non-significant difference of going between 5% in the control up to 11% in the intervention. And then Christy Patton in the US looked at counselling and self-help materials with Alaska Native women, no difference between intervention and control. And more recently, she looked at providing messages about cancer risks for the baby, and again, no difference between the 2 arms. We have got quite a few pilot projects that are going on, and some of those results look promising. So just to talk a bit more about my specific research, and I'm going to really just focus on Indigenous women, although I have a trial with Adrian Dunlop where we're looking at women attending substance use prenatal clinics, but I did talk a little bit about that on the pre-conference workshop day. So the principles for developing our work, what are they? So there's kind of 3 main components. Co-development is critical, and we use a collective and negotiated design, working closely with Aboriginal services, and also it's very important to respect Indigenous knowledge in that area, and it's not just all about science. It's important to privilege Aboriginal voices in this work. It's important to be transparent. So it's important to communicate well with our stakeholders and publish everything that can be published so we can show people what we're doing along the way. Because, quite often in studies, they have a little paragraph about how they developed the study. That's not enough. We need to be really clear about that. And we need to, in our rigorous side, we need to use theory-informed approaches and whatever the best design is to answer the research question. And this came out a little bit out of a national study I did in 47 organisations, half of which were Aboriginal, looking at how they developed their messages. And when I did a categorical principal component analysis, there were clearly 2 kind of sort of streams to that. There was the cultural understanding, really understanding your population, what it's all about, having those deep messages, and also rigour, having those theoretical frameworks and evaluating. And it's like a tree, and it's growing, the roots that are nourishing that tree are our scientific side, but the Indigenous knowledge side. And if you want to build the evidence, you really need a mixture of both. That's what best practice is going to mean. But we start with women's stories. So this is some artwork done by my PhD student, Michelle Boville, who's about to graduate soon, we hope. And the artwork's reflective of a midden site, which is a sacred site for Aboriginal people, a place they've sat around for eons, had ceremonies, sat and talked and shared. And these precious stories are like multi-layered artifacts in that midden site. And this is where we start. And when you think about it, all quantitative research starts with people's lived experience. And that's really important to acknowledge in this setting. But how do we build the evidence? So, we've used a lot of different things. We've looked at systematic reviews of the literature, should messages be culturally targeted, looking at, pregnancy. I've done systematic reviews across the 4 high-income countries looking at Indigenous population to compare. We've looked at what the barriers and enablers are with theoretical frameworks, calls to action, how we develop those anti-tobacco messages, what are the cultural challenges when doing that work. There are cultural challenges, and even Aboriginal services have cultural challenges when they try to do that. We look at qualitative research. There's been several qualitative studies we've done, looking at the health providers. What are they doing? What are their barriers? What are their factors with prescribing NRT? Writing my own guidelines with Renee Batoon, because nobody else had really written any. Looking at how we design this with theoretical components, just being really clear, validating those early things that we developed with the resources for health providers and validating them with Aboriginal women, publishing our protocol for a pilot study, and then just recently this one was our first results that have come out with the pilot study, which I did talk about in the late-breaking abstract. So when we work with Aboriginal community-controlled organisations, I like to start small, like work with a couple of organisations in depth where we can meet people face-to-face, develop some things, and then test them further out, in its ripple effect going out, testing them nationally. The staff who we work with worked in maternity care, and then we also sent all of this resources out to expert panels, mainly targeting Aboriginal researchers and clinicians, but also going out to international experts, and then trying out our messages with focus groups, both with health providers and Aboriginal women to pre-test, have we got it right, and then making changes again. And then, behind it is our toolbox for intervention design, using implementation science approaches. So that's understanding the behaviour and what is that behaviour that we want to change. And then systematically selecting the appropriate intervention functions and policy categories. What are we going to use to bring about that change? And what are those active ingredients, those behaviour change techniques? How are we going to just nail it all down? So, for example, this is just part of a table from one of my studies where I explained what we did and how we developed this, how we targeted health provider behaviour. So, looking at what are their barriers, and then looking at the theoretical frameworks to try and understand how that's categorised, and looking at what behaviour change techniques are and how we're going to now translate that into the Indigenous context. Because our feeling was like, if we don't lift our game as health providers and start actually helping people quit smoking, how do we expect Aboriginal and Torres Strait Islander women in pregnancy at a vulnerable time, how do we expect them to quit if we can't even help them? So we also wanted to make that connection between chronic disease for women, and the women in our pilot study got this little booklet which has augmented reality videos, so they can download a free app and then they just hold that over a picture in the booklet and they get a lot of videos. So they can, and all of those messages are from Aboriginal people to Aboriginal people, developed by Aboriginal people. So it's not me talking to them. So I'm going to actually just show you a little video clip here.
When you take a drag or a puff on your cigarette, you're inhaling all those chemicals into your lungs. Those chemicals get absorbed into your bloodstream, and then once it's in your bloodstream, the carbon monoxide and the nicotine is all travelling around your body to your bloodstream, and that will include going through into the placenta and then across the baby. So that's how the smoke gets to your baby. So all those chemicals that are now in the placenta are going to baby doesn't grow as big as it should to its potential. It tends to be a bit of a smaller baby. And it also affects its organ development, so things like brain and lungs and even their ears. So those effects sometimes you don't see till they get older. They can grow up and get problems like asthma, glues during childhood, and then into adulthood they can get things like diabetes and heart disease. The environment the baby gets exposed to makes a huge impact on that baby's long-term health into adulthood.
So, we want to have accurate messages that help women understand what's happening, but we don't want them to be too scary, because we know also from some other research I've done that if messages are too scary and women have low efficacy to quit, then they're just going to just switch off to the message and go into denial, and it's like too hard basket. So, but women do want to know. They want to know, and they want to have accurate information. So we've developed an ABCD approach, so it's modelled on the New Zealand approach of the ABC, but added a D. And the D is to discuss the psychosocial context of smoking, because that's one thing that we have to remember to do. And it's particularly important in this work where women are surrounded by other people who smoke. And we know that's really hard. It's hard if everybody's smoking in the house, particularly hard if the partner's smoking. It's hard if women, don't have security, food security, or a home, or they're experiencing domestic violence. So we need to be able to go through all of those things with women and, address those things and advocate for her where we need to. So I did explain about the pilot study results that we've done just the other day, but we're basically aiming to change provider behaviour through interactive webinars that are short. They're only like about 3 hours long. It's not like going for whole, and we are actually going to be shortening those now even more, but just really getting to the nitty-gritty bits they need help with, which is the assisting, the cessation, and the discussing the psychosocial context. We provide a whole resource package around that. Women get free oral NLT, which is not subsidised in Australia. They can get the patches on prescription if they need it. And I've shown you the booklet, which has also got some cool other features, and I've got one with me if anybody'd like to see it. And that primary aim was feasibility and acceptability and what we needed to change. And we did get a long list of the things that we did need to tweak. And we have measured changes in the health provider behaviour and quitting activity in women, and a whole lot of process measures. And now we're up to our more major trial, which is going to be national. So this is why, right from the beginning, it was important for me to do my work on a national basis. And for people who are not aware, there's about 300 different language groups of Australian Aboriginal and Torres Strait Islander people. There's a huge amount of diversity. And if a lot of studies are just done in one area, but if you want to have that transferable and generalisable to people across Australia, you do have to take the broader view. It's really important to respectfully be able to account for diversity. So we are recruiting 30 Aboriginal medical services across 5 states. We've just randomised our first 10. We're having to do this in waves because it does take a long time, to engage with services. But we have made a start, and our primary outcome is quit rates, because that's the bottom line. Are women going to quit smoking? That's what we want to know. And we're also following up the babies to 6 months, looking at their respiratory health. So there are some other approaches going on, just to indicate that there are other types of pilot studies happening in Australia, and I'm part of some of those. Like, for example, we're developing a mobile phone app for pregnant women, which is going to be multi-behavioural. So it's going to look at social emotional well-being. It's also going to look at smoking, alcohol, nutrition, because a lot of these problems cluster together. Hardly anybody has smoking as their only issue. And And there are some other things which we're keeping an eye on, and hopefully we'll get to a point of being randomised trials eventually. So what do we need for future research? Well, we just need more research, but there's no research on partners. It's like there hasn't been a single, even qualitative study done on Indigenous people's partners in Australia. So we need to do work on that. We're having trouble getting funded for that, not without trying, but hopefully we'll get that eventually. We need more family and community approaches. We need to focus more on that social emotional well-being aspect overall. And, you know, Aboriginal and Torres Strait Islander women do use social media a lot, and a lot of the women coming into pregnancy are quite young. So this is a great opportunity to be able to get, you know, something in their hand. They've got an app and a phone. They've all got smartphones, most of them. You know, if they've got something in their hand they can use, that could be really helpful. But overall engagement is a really important part. If you don't engage people in the appropriate way, respectful way, you're just not going to get anywhere. So I think that's the important message I'd like to just end with. And I'm happy to take any questions if we have time.